It is my pleasure to introduce the last session of the day, but definitely not the least. I've seen some of it, and it's all about access. And this kind of is the glue that brings a lot of what we've been talking about together. How can we prevent AMR in future? So it is my pleasure, first of all, to start with a video, and then I am going to invite Sophia and later Christine to come to the stage and do the last session of the day. Can we have the video, please?
Why is EU-JAMRAI2 focusing on access?
So that the patient receives the right antibiotic at the right dose, at the right time, and for the right duration.
When the right antibiotic is not available or reliably available, doctors, veterinarians, and other prescribers resort to treatment alternatives, which may be suboptimal and contribute to the development of resistance. So, sustainable access to effective antibiotics is vital to every health system and a cornerstone of containing antibiotic resistance.
So what are we doing in EU-JAMRAI to concretely strengthen access?
Firstly, we continuously gather the available evidence related to access to antibiotics, for instance regarding demand, supply, and possible strategies to strengthen access. We share these findings through webinars and other means to make sure we are up to date on what is going on in this field.
Secondly, we identified those products that we are focusing on. This interactive map on the EU-JAMRAI website, one of the first results of our work, shows with a simple click the focus products that each participating country have identified, together with their national experts and stakeholders.
These are antibiotics for human or veterinary use, or veterinary vaccines, that are of medical importance with vulnerable national supply. This could mean they are often in shortage, they were never marketed, or they are withdrawn from the market.
So as you heard in the video, in EU-JAMRAI2, we are working on concretely strengthen access. Firstly, by gathering and sharing the available evidence in this field. And secondly, by identifying national focus products of medical importance and with a national vulnerable supply, an activity that was completed during last spring. And thirdly, which was not mentioned in the video, since last fall, countries have been working on analyzing the specific barriers to access for each focus product in the national context as well as from a European perspective. The barriers have been investigated from different perspectives to uncover, for example, economic, regulatory, supply chain, or usage-related barriers to sustainable and reliable access. And this analysis is now nearing completion and has been done with vital feedback from the pharmaceutical industry and in collaboration with national key stakeholders. A clear and detailed understanding of these barriers to sustainable access will help us to tailor interventions to strengthen access to the particular antibiotic in the specific country, which is our next main activity. These interventions can be national, multinational, regional, or European, and EU-JAMRAI2 will develop and support implementation of these interventions. And throughout this process and through EU-JAMRAI2, we are fostering strong collaboration and communication within and between national and regional stakeholders that are working on access to antibiotics. And to better understand EU-JAMRAI work on strengthening access, we have chosen to highlight two cases for you today. One from the veterinary and one from the human side, each case introduced by a short presentation and then followed by a panel discussion. And we will start with the case of benzylpenicillin for veterinary use. So please welcome Cristina Muñoz Madero on stage, who will explain to us why sustainable access to benzylpenicillin for veterinary use is a critical challenge. Welcome, Cristina.
Thank you so much, and good afternoon, everyone. Yes, I tried to highlight why benzylpenicillin is very important for the vet field in 2 minutes, because I know what it means to be the last session of the day, so don't worry about that. Why is important? Well, the first point is that benzylpenicillin is a narrow spectrum antibiotic, which means that is the first choice for the treatment. But I don't know if you are familiar with the antibiotic categorization that we have in the vet field, but we have 4 groups, from D to A. And D is the first choose antibiotic. So this benzylpenicillin belongs to the category D. So it's narrow spectrum, category D, 2 points in favor of this product. And this product has very good efficacy against different pathogens, and we have this product on the market for more or less all different species, because it's totally different. Human, one species, very easy, believe me. Veterinarian, a lot of different species, and we need to have included in the product all the different species, which is the case for this product. And the pharmaceutical form for this product is injectable. So all points are in favor of use this product. This is a graph from the SBAC report, last SBAC report, and is regarding the cells, not used cells, but it's more or less the same. In relation with the benzylpenicillin, you can see different pharmaceutical form. Blue is light blue is related to benzylpenicillin, and as you can see, we have a lot of difference between different member states, and benzylpenicillin is most used in the north country than in the south. Different culture, you say. Well, now we have legislation in place, veterinary medicinal product legislation. This legislation including this article, 106.1, controversial article. Why? Because this article included that the veterinary medicinal product must be used following all indications included in the HPC. So now it's not possible to use the off-label use. Previously it was possible. It's not possible to change or to adapt the dose of the product to a specific clinical situation. Nevertheless, as was saying in the video, access means to have the right treatment, but with the right dose and with the right conditions. And now we are aware that we have a lot of veterinary medicinal products on the market that are underdosing. Why? Because the resistant profile has changed along the time. And these products are on the market for more than 50 years. So now the dose is not effective anymore. But because this article, we have to use this product even in the case that we know are underdosing. So now it's a problem. Well, because that, we have different ways to update this product, and one of them is a referral. I don't know if you are familiar with the referral process, but in summary, it means that we identify a risk for one veterinary medicinal product or for a group of medicinal products, and initiates a referral in order to update and to avoid, to include measures in the product in order to avoid this risk. Well, in relation with this benzylpenicillin, procaine penicillin, it was identified that probably the dose regime was not the right one, so we initiate the referral process. We assess all information that we had at that time in relation with the different process, and the conclusion for this referral was that the dose rate and treatment duration for some of this product should be increased. So it was, it was. Now the dose regime for this product have been updated, and now we are aware that these products are on the market in the right, with the right dose and the right treatment duration. But nevertheless, to use or to recommend this product have challenges, and the challenges is that this product is a globally critical medicine, so it's using a lot, and there are few EPI manufacturers for this product. So what is the results of this combination between the demand and the supply? Well, the result is that we have a lot of shortage about this product. So we are recommending one product, but at the same time we have problem with the we have shortage with the product. So we are working on that in the frame of this working group 9, in order to try to avoid this problem and try to put on the market this product without any problem. Thank you so much.
Wonderful. So let's see. Now we've got a panel discussion. We're going to do things a bit different now. So people, you have questions about benzylpenicillin. So when you have a question, come up and stand over here or over here. Someone will come and give you a mic. So we really want to encourage questions from the audience. So I want to welcome the panel. We have Cristina that you've already met. We have Pascal, Tita, and Anna. Great. I think I'm going to sit, if that's all right. Wonderful. So you see their information here, so we won't go through introductions, but we'll start with the very first question. And this is a question to all the panelists. From your perspectives, what do you see as the benefits and challenge to the revision of the benzylpenicillin treatment duration? And we'll start with Tita. I think you have a microphone.
Yes, thank you. Does it work? Yes. Benefits and challenges. I would say that if any of the use of broader spectrum antibiotics has been switched to use of penicillin due to this referral, then that would be a benefit indeed. And there were also some pathogens mentioned in some of the really old penicillin products where we didn't really see that there was any efficacy against, and those were deleted. That was a definite benefit. Salmonella, for example, was mentioned in some of the SBCs. It's not a place for salmonella. And also the very low dosages that Cristina mentioned, they were deleted. That was a benefit. However, the challenge and our fear was that there would be a requirement to do new residue depletion studies, and those are very costly. And it was our great fear that due to this requirement, some of the products would have been withdrawn. Luckily, that didn't happen.
Cristina, same question.
Well, I think that now we are happy because we have this product update product on the market, but nevertheless, there is still a problem in relation with the withdrawal period. In the vet field, it's very important, the withdrawal period, and if you have on the market one product with short withdrawal periods, as cephalosporin, for instance, and you have this penicillin product with very long withdrawal period. Normally, people go to the cephalosporin before this product. Nevertheless, I think that the referral process was very good process, honestly, and I think that after this referral, people, for instance, in Spain, we know that the consumption increased after this referral process. So I think that we have very, very good advantage to use this product. The challenges I put on my presentation, there are different challenges, and the first one is that we have frequently a shortage age for this product.
Yeah, so good afternoon, everyone. So from the procedural point of view, at EMA, I would like to highlight some challenges. So these are very old products. So when assessing this data, the committee faced the issues that there was not up-to-date data in line with current scientific knowledge, and this one was one of the challenges. And also another challenge that the committee faced is that in a referral procedure, you need to assess all available data, and you need to discuss and to reach a harmonized position across all EU member states. And this was a challenge because, of course, the national policies in the different member states are different, and trying to reach a common approach was really a challenge. But I would like to highlight that instead of focusing on these challenges, I would like to emphasize that it's important to focus also on the solution, the potential solutions for these situations. And I would like to take the opportunity today to mention an ongoing EMA CVMP initiative that is called the ADRA project. That is the dosage review and adjustment of veterinary antimicrobials. And this would be performed by the Committee for Veterinary Medicinal Products. And the main idea is to, instead of requesting pharmaceutical industry to perform studies, that it was the case of is similar to the outcome of this referral. So instead of requesting companies to provide new data, it would be for the committee to follow this non-experimental approach. So in a way, it would be by modeling, PK/PD modeling or extrapolation of data. So the outcome is to review and adjust the dosages of the products, the antimicrobial products, but without costly procedures for the industry. Thank you.
So I think that leads well to you, Pascal. What do you
Good
think?
afternoon, everyone. So on behalf of the industry, we see a benefit that it brings harmonization in the market. And harmonization means that it gives clarity for the veterinarians and consistency for the market. And we see that as a major advantage. Another advantage is that we as an industry, we support the AMR. We support the responsible use of antibiotics. If I look to my company, I represent Keuleyan, but also Access VetMed, so the industry of the manufacturers in Europe. We manufacture and we sell more than 70% of our sales is antibiotics. But in our mission vision, we stipulate that we strive for responsible use. Yeah? And that One Health approach is key and is also in our mission and vision. So we have set up a Keuleyan Academy where we teach the farmers, where we learn the veterinarians, yeah, how to use and how to implement antibiotics in the field. And we walked away from the mass consumption. And today we focus on individual treatment. That means if an animal is ill, yeah, we go for the individual treatment of the animal. So as the industry, we support of everything that we discussed and what was presented this morning. The challenges, I don't see a specific problem on the benzylpenicillin because there was a very pragmatic approach on this case. In general, of course, referrals could lead to high cost and that one or more manufacturers could withdraw a product, which is not the case on the benzylpenicillin.
Well, that's great. It's great that we've got the first one that seems to be successful. But Tita, 5 countries, most of the Nordic countries, selected procaine benzylpenicillin as a critical antibiotic with vulnerable supply. So why the Nordic focus?
Yes. Let me start with the antibiotic use guidelines in Finland. They have been in place for 30 years now. And if I had to tell you in 2 sentences what they contain, what is the essence of these guidelines? Do you really need to use an antibiotic? Do you really? And then if the answer is yes, I really, really need an antibiotic for this animal, then look at you must know the pathogen, what is its sensitivity, and treat the individual. Just like Pascal just said, treat the individual. And if the pathogen is sensitive to good old benzylpenicillin, it must always be used. It is the first line treatment. Well, how did we succeed with these guidelines then? If we look at numbers from ESVAC, the proportion of sales of injectable veterinary medicines of all antibiotics sold in Finland was over 60%. In Sweden, I think it's almost 80%. And if you look at the proportion of beta-lactamase sensitive penicillins of all antibiotic sales, it is approximately half in Finland, and I think 60% in Sweden maybe, which is in its own class. And when you look at the aggregated numbers for 31 countries, injectables, 14%, and beta-lactamase sensitive, 3% in the EU. So these numbers really tell us what it's all about. Injectable benzylpenicillin is the foundation and the cornerstone of treatment of production animals in the Nordic countries. And this explains why there was a complete panic in 2015 when there was a global shortage in penicillin. Because if we don't have penicillin, we have to use broader spectrum antibiotics.
I think that leads on to Cristina then. And remember, people who have questions, please come over to the side of the room and so that you can ask a question to the panel. So Cristina, and if there's any online, Luis, you'll tell us, I imagine. So Cristina, because of this referral, you mentioned that Spain, it seems like consumption of benzylpenicillin has actually increased. Can you tell us more about that? Why is that?
Yeah, well, this is true. Nevertheless, we are still waiting for more, use of the benzylpenicillin injectable. But nevertheless, I would like to highlight that the production situation is totally different in different member states, different countries. So thinking about the production in Spain, for instance, pigs or poultry, it's really, really difficult to go for an individual treatment. It's more or less impossible in poultry. And in pigs, it's really, really different. So we still, even in the case that we have the first choose in Spain is still penicillins, but nevertheless still oral route, because it's more for mass medication, and in a specific case it's really difficult. But nevertheless, we are happy because we increased the use of benzylpenicillin in injectable benzylpenicillin, mainly in small ruminant, which is easier to treat individual or other production where the individual treatment is possible. So we have the balance between the possibility to use this product in individual way and the other production where the injectable products are more or less difficult to use. And this is the situation right now.
I think I see a question.
Thank you very much. Yeah, Nancy de Brienne from the Federation of Veterinarians of Europe. And first of all, I must say I'm really happy that this issue has been discussed here and the issue has been put on the table. The problem with benzylpenicillin, but just more in general also the problem as veterinarians we have with Article 106.1. Because benzylpenicillin, yeah, the referral has been done, which is really fantastic, but the problem is we have many other products where the SPC is not any more up to date or where the SPC is different between different countries. And I think it's pretty difficult to do that for all these products. So a more sustainable solution should be found to address this. Another problem we have is that as veterinarians we always have to use the product authorized in the country. Even if antimicrobial stewardship guidelines say you can use a more narrow spectrum one, or you see it in the diagnostic test, you can do it. We're not allowed if that one is not authorized and a more higher risk one is authorized. So there also I think veterinarians should be given the possibility to use antimicrobial stewardship guidelines and promote the decrease of resistance. Thank you.
I think that's a good one for you, Anna, about flexibilities. What kind of flexibilities are there with the 106.1?
This is a very tricky question. I understand the concerns expressed both by veterinarians and industry, even by member states. But this is what the regulation says, and there is nothing we can do. This is coming from the parliament, and this was a text agreed, and I mean, in a way, there is nothing we can do. The regulation says that the product needs to be used according to the terms of the marketing authorization, and unfortunately, there is nothing we can do regarding that.
Okay, that's Pascal, from your perspective, how do you see these flexibilities, or how does it impact industry?
Well, I think first of all, referrals are essential, yeah, and we support that because it ensures safety and efficacy. Yeah? But what is very important, if these referrals would lead to many tests, to a highly cost, to what I would say an administrative burden, then there is also a risk that companies start withdrawing the product from the market. And we believe that on the long run, and certainly for these benzylpenicillin, which is a first line product, that the products remain available, and hopefully more than one, so that the veterinarians have an option to choose for which product they would go. But we applaud very much the pragmatic approach of the authorities in this case, that no extra studies were needed. And because of this decision, the companies will keep the products on the market. So our conclusion would be, yes, referrals are absolutely needed, are essential, but that we have to find a very good balance between safety and efficacy. Yeah? And on the other hand, that most of the products would stay on the market, so that the products remain available and that the users, the end users, have choice between one to more than one product.
There's not a lot of new veterinary antibiotics coming out, are there? So, but have you, as industry, have you seen a positive result from the referral? Have you seen increase in sales?
No, not yet. I think for us it is more or less stable. So that means that we believe that none of the manufacturers so far have withdrawn the product. Okay. Yeah.
Good. Yes, question online.
Yes, oops. So we have a couple of questions. Two are coming from the Statum Serum Institute, one from Ute Wolf-Skansken and another from Signe. So they are happy to hear that they are updating the dossiers through the expert group at EMA. What are the expectations regarding the time frame for this? And why is data on 50 years use of benzylpenicillin not enough to update the dossiers? So maybe for EMA, Anna? Yes,
so for the first question, I guess they are asking about the JAMRAI project. This is a CVMP EMA initiative. It's ongoing. There has been a lot of discussions already, and this initiative that the main aim is to minimize the occurrence of resistance in the Union would be presented to industry, because those are the relevant stakeholders in this case, and it will be presented at the end of May, hopefully on the 22nd of May. So this event is already on the EMA website if they want to find more information.
Okay, because there was a comment also about the other project from ANSES that they say that we still need data to inform pharmacokinetics and pharmacodynamics modeling for the revision of the dosing regimens of antibiotics.
Yeah, to complement the answer, the objective is to use PKPD model and other mathematical model in the very pragmatic way in order to update globally all class of antibiotic all together, and a very pragmatic way, because we need this product on the market, because all of them are first-line product.
Maybe Tita, could you talk a little bit about, because it seems like decisions are being made based on Europe as a whole. Do you think that different parts of Europe perhaps use these antibiotics differently, and that should be taken account of in these referrals?
Well, this is obviously a very sensitive question, and let me just say that it is good that the industry remains positive towards harmonization, and it is good that we will harmonize all products. However, veterinarians they have given an oath when they start the profession that they will follow all the academic research in the field and use their best knowledge when treating each animal. So now we have this very rigid 106.1, which doesn't take into account that you will always have these animals that have a different metabolic state, for example. We will never, ever be able to harmonize all products to this degree that you would have a dose for a random animal that has this metabolic issue. So the veterinarian should be free to adapt the dose and the dosing length to the individual situation. So the problem is really not maybe the lack of harmonization, but the problem is 106.1. Now I said it. And I also think that if the authorities in each country are wise, they will understand this. And they will not maybe, it says in the SPC that you should use this with 20 mg per kg for 3 days, and the veterinarian sees that this animal needs it for 30 mg per kg for 4 days, where is the crime? This is something that I think that we should all think about. Because we also have EU legislation on animal welfare, and every veterinarian must take this legislation into account and treat the animal in the best way possible.
Thank you. So, one last question. Oh, you've got. Okay.
There is one more question online from Animal Health Europe, from Diana Teixeira, who says that the vet market has specificities, being small, fragmented, and no public funds. How to build a business case and the risk critical medicine supply?
Anyone want to take that one? Go ahead, Cristina.
No, thank you. Debate, have more comment on that.
This is for the panelists. Yeah?
Yes, so given the specificities of the vet market, how to build a business case and the risk critical medicine supply?
I think this ties in nicely to our last question, because I think another problem that we heard Pascal mention about benzylpenicillin is Cristina mentioned in her presentation, few active pharmaceutical ingredient suppliers. And a lot of veterinary medicines were very dependent on very few suppliers, and many in Asia, as I understand it, although the data is not very clear. So
absolutely.
Yeah.
And we as an industry, we have to buy all our penicillin in Asia. There is no, for us, there is no penicillin available in Europe. Yes, there is a manufacturer, but it's not available for us. So all the penicillin from the industry is bought in Asia.
So the question that I was going to ask is, what can we do in EU-JAMRAI? We've got 3 years now. We've got generous financing from the European Commission. What can we do to help strengthen the access of narrow-spectrum old antibiotics like procaine benzylpenicillin for veterinary use? So whoever wants to start.
If the question is based on the API?
No, we've got 2 minutes.
Yeah?
2 minutes.
if the question is based for API?
Or more generally.
Yeah?
Yeah.
On API, sorry, I don't see a solution, because building a plant manufacturing API, there is one manufacturer, but who doesn't give access to the industry. Yeah? So there is no option, and manufacturing, building a plant for API, it will take years with high environmental costs. Yeah? With a huge investment. So in the coming 3 years, I don't see a solution. The same also for manufacturing the finished product, the benzylpenicillin. If I look to the long-term future, you working into campaign, will be banned. Now, we have done an investment with dedicated lines, so we are well prepared for the future. Yeah? And I think which is absolutely necessary. So on the finished product, I don't see a problem. The main problem remains on the API. And come on, look to the news, also taken into account today's geopolitical situation.
Yep.
Yeah?
Okay, let's not go into that.
No, but
okay, next on the no, then everyone will start to cry. Go ahead.
Well, I guess the access to veterinary medicines is more related to both NCAs in the member states and industry. So the EMA has only a coordination role. So I don't really have something really important to mention here. Sorry.
That's okay. Cristina.
Well, we try to work at national level in order to identify the potential shortage in advance, in order to try to cover this problem. I fully agree with Pascal that in the next year it will be impossible to to find a good solution, because the solution is on the AP manufacturer, so this is the big problem. But nevertheless, we try to take a solution in advance and recommended an alternative to this product. Nevertheless, the recommendation for the European Commission may be, if we need this product on the market, the recommendation from them is to use this product. Well, we have to work together in order to find the solution, for instance, flexibility to the 106-point article, in order to be sure that these products are used in proper way in the field. This is the most urgent issue for us.
And Tita, quickly, last word. Thank you.
Yeah, quickly. Something that I just came to think of, I don't know the recent developments, but a few years ago, the Commission was committed to try and incorporate emissions of active substance during production in the environment into GMP. So I wonder how this is going forward, because if this would happen, then I think that the emissions during production would be a real problem in the third world, and therefore maybe it would be more economical to transfer the API production into EU and get it back. Maybe.
There we go. That's the kind of positive we're looking for. Thank you so much. That was wonderful.
Oh, there's the slides. Okay, thank you so much to all of the experts in the panel for this interesting discussion. But now we move on to the other half of this session and to the human side, where we will focus our second case to highlight our work on WHO access antibiotics. And our efforts on strengthening access within EU-JAMRAI2 are in line with several items that emphasize access to antimicrobials in the 2023 EU Council recommendation. For instance, that member states are encouraged to assess and address antibiotic supply chain vulnerabilities, improve the continuity of supply of antimicrobials, and promote in a coordinated way with national and multi-country initiatives the accessibility of antimicrobials. But for this session, we wanted to highlight one target in particular, which is this one, which has been shown before today, that member states are invited to take appropriate national measures aimed at ensuring that by 2030, at least 65% of the total consumption of antibiotics in humans belongs to the access group of antibiotics as defined in the AWARE classification of the WHO. And AWARE, of course, stands for Access, Watch, and Reserve. And the access group from the WHO AWARE classification, which you're probably aware of, consists of first or second choice antibiotics that offers the best therapeutic value while minimizing the potential for resistance. And the importance of using a higher proportion of antibiotics belonging to the access group when appropriate was also highlighted in the UN political commitments from last year. But to reach these targets, the antibiotics must be reliably available in the member states. And when they are available, they also need to be prescribed and used where appropriate. So working on increasing access to these antibiotics is, of course, closely linked to stewardship measures. And through EU-JAMRAI2, countries are working towards this target by having identified the need to strengthen national availability to 14 antibiotic substances belonging to the WHO access group. And you can see them here listed on the slide at the bottom. Quite small text, but it's there. And these are older antibiotics mainly, and we see products used in primary and in secondary care, and in different formulations and also strengths. And of course, potential interventions to strengthen access to these will differ depending on the type of product and also the national context, as well as the national barriers that the countries have identified. Some of these WHO access antibiotics are of common interest to several countries, and for these we see potential for multinational or regional interventions and collaboration to strengthen access. One example is phenoxymethylpenicillin that 11 countries are focusing their efforts on. We also see that many countries have a common interest in strengthening availability to WHO access penicillins for pediatric use. Let me see here. Yes, 85% of countries are focusing their EU-JAMRAI2 efforts on strengthening access to pediatric formulation of penicillins, such as amoxicillin and phenoxymethylpenicillin. Pediatric formulations are mainly oral suspensions or oral solutions, so liquid dosage forms, but also smaller and lower strength tablets. And we're not surprised that this particular group of products are of interest to so many countries, as there are recurrent problems with reliable access to narrow-spectrum antibiotics for pediatric use. They are known to have frequent shortages, and they are at risk of market withdrawals. And of course, children are one of the most vulnerable patient groups where it can be hard to find treatment alternatives, since many children are unable to swallow pills. So our next panel of experts will delve into these access pediatric penicillins, specifically amoxicillin and phenoxymethylpenicillin, exploring why countries are focusing their EU-JAMRAI2 efforts on these, as well as the main barriers to reliable and sustainable access and potential future interventions. And with that said, I invite Cristina to moderate this panel discussion. Thank you.
Good job. Okay, so please, distinguished panelists, come take this stage. So, same discussion, same way as before. Please, if you've got questions, come to the sides and ask your questions. As you can see, we are focusing still, same topic, human side. Older, important, critical antibiotics that have access issues. So please look at the descriptions of the panel here so that you know who you're talking with. And I am going to start off with you, Emma, and Alban, and Michael. So your countries have prioritized strengthening access to pediatric penicillins within EU-JAMRAI. Why have your countries selected those antibiotics, and what are the main barriers to reliable access? So Emma, would you like to start first, please? Do you have your microphone next to you? Or...
Dear Chairman, dear colleagues, phenoxymethylpenicillin is missing in Bulgaria since more than 5 to 6 years. Phenoxymethylpenicillin is used to treat infections by Streptococcus pyogenes. Maybe you remember that in the year 2023 there was a resurgence of cases of scarlet fever and Streptococcus pyogenes tonsillopharyngitis. Patients could not be treated by phenoxymethylpenicillin, and they were prescribed amoxicillin clavulanic acid. At that time, the lineage M1 UK was found for the first time in Bulgaria. It produces 9 times more of streptococcal pyrogenic exotoxins PA than the other Streptococcus pyogenes strains. The other antibiotic, amoxicillin, is available in Bulgaria. It is widely used by specialists in dental medicine. Majority of GPs, pediatricians, otorhinolaryngologists prefer to prescribe amoxicillin clavulanic acid. This is related to the higher levels of antibiotic resistance in Bulgaria. 50% of Haemophilus influenza are resistant to amoxicillin, and more than 20% are penicillin non-susceptible and amoxicillin resistant. Thank you.
Excellent. Let's go on to Michael.
Okay, so you asked why pediatric penicillins. Well, first of all, because we have a problem. And you always intervene when you have a problem. So if you look at our aware classification, Malta is around 56%. So we're way below the 65. And a substantial component of that is, or are, prescriptions for children. So clearly that is a very useful low-hanging fruit that we can address. Secondly, thankfully, our primary pathogens are still sensitive, so we still have 99% sensitivity in strep pyogenes and 98% sensitivity to strep pneumonia, so it's useful, because if we did have lots of resistance, then it wouldn't be really worth the hassle. And finally, because we have a current situation where the alternatives that are being prescribed, primarily second-generation cephalosporins, Amcom, and especially the macrolides, the newer macrolides, they are driving resistance. So we're seeing, for example, macrolide resistance very much linked to consumption, and therefore that's something we want to address. So clearly those are the three main drivers for our intention. And finally, in the adult population, we already have reasonable, I wouldn't say extraordinary, but we have reasonable alternatives. In the pediatrics, we don't. So that's why we're moving in that direction.
So Alban, when it comes to France, France is one of the largest countries in Europe. It just seems very surprising that you have shortage problems with the antibiotics like amoxicillin. Can you tell us more about the barriers to access?
Yes, we had in the past two important shortages with penicillin for pediatric use, essentially due to the fact that during the winter season, we have a lot of prescription in children, but the problem is that we have only few actors, few pharmaceutical companies who can provide the pharmaceutical forms for children. So with high demand, but only few actors, few pharmaceutical companies available for this kind of product, therefore we faced in the past two important shortages. Without the possibility to have the adapted pharmaceutical form, essentially, for example, for oral suspension. Therefore, we proposed extemporaneous pharmaceutical forms, pharmaceutical preparation in pharmacists, with the pharmacist, in order to manage these shortages. So the problem is that for other antibiotics for children, especially for oral suspension, for example, we have selected for the work package 9 several products because there is only one MH for this kind of this kind of product for the children. So if there is a difficulty, if there are some difficulties to produce, to manufacture the products, therefore there is no other similar product. And then what we have seen, we have seen that the prescribers would like to prescribe other antibiotics, like macrolides, for example, because they are macrolides for oral suspension for children, but it is not systematically, it's not the good choice, because there are a resistance, and this kind of other antibiotics can produce more resistance, and then this is the problem that we have. So there is a need to maintain this kind of formulation because the population, the pediatric population is small comparing to adults, but the price of the oral suspension for children, the price is higher compared to tablets for the same antibiotic, for example. So I think that we have to create a framework sufficiently attractive for the companies to maintain this kind of formulation, because we know this is a general situation, not only for antibiotics. We know that we don't have sufficient pharmaceutical forms for children for many medicinal products. But this is the problem we have with this kind of product for children. So yes, it is very difficult to maintain this kind of medicinal product for children with only one MH, which can provide this kind of product.
I think Alban put it very nicely, which lays it over to you, Bo. Can you tell us a little bit about what are the challenges for industry, and what are some of the solutions that you're seeing for the pediatric penicillins?
Absolutely, more than happy to. Thanks, Christine. So look, I think we have to set the stage by saying when we talk about supply sustainability and responsible access of the pediatrics, but quite frankly speaking, generics as a whole, they face similar issues, and there's two major threats. The first one is antimicrobial resistance, which we all acknowledge, and the second has to do around the existing market framework that, quite frankly speaking, has its challenges. It also has its failures. It's not functioning the way it should. So when we talk about how can we improve it, it's important that we understand the challenges. Now, the challenges, the common denominator, whether we're talking about a pediatric or generic antibiotics as a whole, it's the same. Of course, we acknowledge that it's more exacerbated within the pediatrics, but fundamentally it's the same issue. So when we think about antibiotics, they're treated largely as commodities, right? So they are priced usually very low, and payers do not consider any other criteria other than cost, right? So no environmental criteria, no quality, nothing. And what happens then is, of course, the difference between a commodity and antibiotic is suppliers have to manufacture at fixed price levels, regardless of external factors like inflation, complex regulatory pathways, or cost of good increases. And so I'd like to really give an example on what that does. It causes this downward pricing pressure. And so let me give a real clear and shocking example to all of you. I would like every single one of you, the next time you buy a coffee at your favorite coffee shop or your favorite barista, remember that cup of coffee is approximately 27 times more expensive than a daily treatment of amoxicillin. An essential antibiotic, an essential medicine, is 27 times cheaper. And this is simply not sustainable. On top of that, antibiotics particularly have huge volatilities, right? So you have pricing pressure from one side, and then on top of that, you have huge demand swings, right? Caused in part by, as we know, a strong respiratory season, which definitely infected all the population, but also pediatrics. And on the other side, you have one of the most unprecedented increases in inflation ever seen in a generation. And so you have things like, for example, raw material costs, things needed for the production of these essential medicines skyrocketed. If you compare prices of 2019 versus 2024, sugar, an essential raw material, went up over 130%. Energy, which is very intensive and needed for fermentation, which is the bulk of what's needed for penicillins, went up over 50%. And so when you have this pressure coming from both sides, downwards pricing pressure on one side, and then cost of good increase, essentially what's going to happen is consolidation of the market. That means manufacturers drop out. You get into a situation potentially where you have one marketing authorization holder, and it's simply not sustainable. And you can see this if you look recently at shortages in the last year or so between 22 and 23. 2 out of 3 of these medicines had a low supplier count. So clearly this is something that must be addressed, and that's the real theme. It's how can we get to supply security? And what I really like to hear, we already heard it from the other panelists, but also we heard it from the panel before, there's so many similarities when it comes to the challenges also on the veterinary side of things. And I think there's a lot of learnings we can take from both sectors as well. Last thing I will say here, because I'm aware of time, is what was already mentioned very nicely on the presentation before, this dependency on foreign suppliers for APIs. We want to avoid at all costs being reliant on a single source supplier, especially if this is not sourced in Europe, because this can induce, and we've seen it in the past, longer shortages, right? Which ultimately does not benefit the patient, right? Because then, as we heard, other treatments have to be made there. So I'll pause there and happy to circle back if there's more time.
Great, thank you very much, Bo. Amelia, I think this tailors goes nicely over to, because the EMA has been doing a lot of work on shortages. Can you tell us a little bit about that and what you see as not only the challenges, but some of the solutions that you're looking towards?
Yes, absolutely, and thank you, Cristina, and good afternoon, everyone. From the EMA side, we have actually been taking a lot of reactive action since global shortages of amoxicillin and amoxiclav in pediatric formulations that occurred in autumn and winter 2022 and 23. What we did at a time when we got the signals from the member states through our medicine shortages working party is we immediately looked at the extent of the situation. So what are the companies impacted, the root causes, whether it's a European issue, is it a global issue? And we engaged in discussions with the companies first to see whether they're able to increase production or if they need any regulatory support from the EMA or national competent authorities, and we were able to provide that at the time. At the time, we were also able to identify some additional smaller suppliers that had extra supplies available to member states that were in a really critical situation. And we also invited the companies to attend the meetings of the mentioned working party and also the executive group, which is a little bit above the working party, and it's composed of national competent authorities, representatives at the executive level, really to engage in productive discussions and agree on EU-level actions. Of course, we did a number of communication activities, but we knew that while we were able to address the solution and react to it when the shortages occurred, we knew that we had to be more proactive and we need to be much better prepared for the next winter. What we did then is we partnered with European Commission, with DG HERA, and we looked at the supply from industry and their supply forecasts for the next winter season. And we also looked at historical consumption and also the demand that the member states expect to have for a set of antibiotics. So we were not only limited to amoxicillin, but we went a little bit beyond that. Based then on the outcomes, we were able to see for which active substances, pharmaceutical forms, and strengths there could be a risk of a shortage. And we were able to issue recommendations through this executive group. And this was done in July 2023. But now, of course, a few years passed, but we have been continuously monitoring and continued our cooperation with industry. Even ahead of this autumn and winter season, we engaged in discussions to see if companies already see some constraints for any specific antibiotics so that we can also alert the member states that they need to prepare for that. I also want to mention the social media campaign. We have launched it now, I think, for the second year in a row. First, to highlight the prudent use of antibiotics and the need to avoid any stockpiling. And I think through all of these actions that we have taken in cooperation with the companies and also the member states, we went from critical shortages in, I think, almost the entire EU in autumn and winter 22-23 to critical shortages in a handful of member states last winter season, and now we have not received a critical shortage notification for amoxicillin and amoxiclav. So I think we're doing, the cooperation that we have has really given a positive impact on the situation.
Well, that's great to hear. You know, I'm curious about what Emma said and what I've heard Michael say before as well, is about a little bit about the demand, that GPs think amoxiclav is always going to be available. I'll just prescribe that. It'll work just as well. Do we have a demand problem for phenoxymethylpenicillin and for amoxicillin? Maybe Emma, you can start.
In Bulgaria, majority of GPs are not very well educated in antimicrobial stewardship. However, professional societies of pediatricians and otorhinolaryngologists follow the rules of antimicrobial stewardship. During the last 4 months, they organized 2 scientific workshops where both young doctors and experts presented really brilliant presentations on antibiotic use. Also, we performed an audit of pediatric antibiotic prescriptions in our ambulatory center, Lozenec, Sofia. The most prescribed antibiotics for both upper respiratory tract infections and pneumonia were amoxicillin, clavulanic acid, and clarithromycin. Only the therapy of patients with bronchitis was not always in concordance with world recommendations, and sometimes these children received antibiotics. Thank you.
Okay, I think it's a bit more complex than that, Chris, and usually complex outcomes are driven by complex processes. So if I could just highlight our situation, you know, I just spent 10 minutes trying to convince you that behavior change is the way we have to go there, and of course, Dr. Heal Thyself. So that's how we've tried to look at our problem, and using the combi model that I mentioned. So it's a combination of all 3 elements. So you have the capability issues. So as Emma said, you know, you find lots of misconceptions amongst GPs. So we've run numerous national surveys, and they consistently come up with the same qualitative quote: oh, that's an old antibiotic, I'm pretty sure it's not effective anymore, and I'd like to use the newer ones. You know, so the first challenge is obviously to convince them otherwise. So that's the first. Then you have the opportunity issue, so the combi, so the O. And the opportunity is exactly what you're saying. And in our country, it's even more complex than that, because we have a really strange hybrid system in primary care, which is very different from the National Health Service in hospitals, where in primary care we have a dichotomy of governmental health centers and then private GPs who work on their own with practically no accountability or supervision, and they are responsible for about 80%, we estimate, of all antibiotics. So it's a chicken and egg scenario. One, we have the supply problems, but then when you try to convince companies to import the antibiotics and the pharmacies stock them, then doctors don't prescribe them, so they have a loss. And then they come back to us and say, don't ever tell us to get it again, because you've just cost me 50,000 euros of medicines I've thrown away. So that's another complex issue. And the third issue is the motivations, the M of the combi. And we know that the single factor that has been correlated with the wide variation of use of broad-spectrum antibiotics in Europe is uncertainty avoidance culture. So again, you know, uncertainty avoidance, the typical 3 words that describe it is just in case. And this is what drives, and we've done pretty, going to publish them through Erika Saliba Gustafsson, and that's the driver, you know. They're unsure that this is good enough, so they want to go for the big guns just to be safe, you know. And then, of course, well, we don't have time, but the interventions have to model the combi items. So capability, how are we going to go there? Opportunity, what can we do? Motivation, how can we motivate them? If there's time, I'm happy to drive on that.
We have already discussed this point, but the problem is that to follow the guidance, but I know it's difficult for the GP to follow the guidance for the proper use, the good use, proper use of antibiotics. And this is the problem, because we have several antibiotics for the first-line treatment, like amoxicillin alone. I think this is the same problem with Malta, we discussed with Michael. But we have too many prescriptions with amoxicillin and clavulanic acid in the first-line treatment. But the first line is amoxicillin alone. So this is a problem because this is not in line with our national recommendation. If the prescribers would like to choose for the first line treatment amoxicillin and clavulanic acid. For the phenoxymethylpenicillin, we have different guidance. For example, in comparison with your country, Christine, because for the same pathology, for the same disease, in France, we prefer to have amoxicillin in first-line treatment. In your country, for the same disease, you would like to choose phenoxymethylpenicillin. This is a different approach, but so in France, we have only one MAH for phenoxymethylpenicillin and only for tablets, not other pharmaceutical forms available. But this is because the majority of our recommendation is for amoxicillin in first-line treatment. So for children, for example, two out of 3 prescriptions are amoxicillin for children in France. So this is a very high amount of prescription compared to other antibiotics. So yes, this is the problem that we have to try to explain, to follow the recommendation, because of course it is important to avoid resistance with other antibiotics which are not the first line treatment.
Thank you very much. Bo and Emilija, same question to both of you. Bo, maybe you can start off. Are there simple interventions that we're overlooking, simple things we should be doing?
I do want to mention one of the activities that actually we're now piloting at the EMA, and it's the shortage prevention and mitigation plans. So the proposal for industry to have shortage prevention plans was already included in the Good Practice Guide to Industry. I think it was published in May 2023. It's also included in the proposal for the new pharmaceutical legislation. And ultimately, the goal here is that we have 2 documents. So one is shortage prevention plans that really would serve as a tool for companies to look at their supply chain, see what the risks are, identify them, and come up with risk management measures. So we expect that this preventive document would already allow to identify some risk areas and hopefully prevent some shortages from occurring, whereas shortage mitigation plan would then be used as a tool when the shortage occurs to give a proposal how to address the issue. So now we are piloting this for 4 products, and 2 of them are amoxicillin, and another one is amoxicillin with clavulanic acid. It's a pilot, so the participation is completely voluntary, and we expect to finalize the pilot in the coming months. So hopefully we'll be able to share some results then. But of course, we also know that whenever there's critical shortages, countries have also used magistral preparations, and for example, EDQM has also done a lot of work on that for amoxicillin and amoxiclav with expert opinions. We know that countries can also use flexibilities in labeling and packaging requirements as some of the examples, and also extension of shelf life also when needed to address critical issues. Thank you.
I see the red cards, so I'll be very quick. Let me start on a positive note. The Critical Medicines Act proposal was released yesterday. They support the meat criteria, right? So the most economically advantageous tender criteria that goes beyond price, considers quality, and for us all in the room, we're here on One Health, considers also environment. Very good. Let's not overlook the importance of supply security. We need incentives and mechanisms in place, as was mentioned before, to bring API production in Europe. Regardless of the cost, it's being proactive. It will secure our future and secure the best treatment for patients. Let's not also overlook, very quickly, stockpiles, national stockpiling, right? This can easily turn, this needs more strategy, I think, and more control, because it can easily turn from stockpiling to hoarding. And I think industry needs to have the power to say, look, we can take a national stockpile and distribute it to any country in Europe that's experiencing a shortage. First, security, then we can talk about simplicity, like pack size harmonization or other things. So I think those would be the 2 priorities. Thank you.
Okay, well, thank you very much to our panel. Big round of applause. And I will be very quick now. So just to give a little bit of a wrap up regarding access. So you've heard Sophia presented to you that we focused on identifying the products that we want to strengthen access to first, both on the human and the veterinary side. We've identified the barriers. We did all of that in the first year. So we have 3 years now to implement interventions and test these. You know, we've heard a lot of ideas from both the vet and the human side today. So we are super excited now. We're going to have a meeting, our second meeting in Copenhagen, May 7th through the 9th, where we will be working on interventions. How do we strengthen access to these products, these older, valuable products? And how do we do that in a European, national, and regional way? So that's the goal of what we're trying to do here. We're trying to actually strengthen the access to these medicines. So if you're interested to learn more about Copenhagen, let me know. We're also focusing on some innovations as well. So we're having a webinar that's coming up looking at gonorrhea. Potentially 2 new antibiotics coming. Yep, I think I have 4 minutes actually, according to my schedule. Okay, I think access always loses out. Is what we're at. But just to finish up here. Gonorrhea, we will be focusing on a webinar because is it now a new time to treat gonorrhea? We have 2 new antibiotics that are coming. We have 1 antibiotic that's not available in any European country. So we're going to be looking at diagnostics. So look for that webinar coming. And we're also focusing on regulatory approaches to bacteriophages, both for veterinary and human use. So if you're interested in any of those topics, let us know. Thank you very much. According to my timeline, 3 minutes early.